Hello, everybody. It's Paula Nutting, your musculoskeletal specialist. And thank you for those people joining live and for all those people who get a chance to listen to this on the recording afterwards. Just reminding you all that we've got a chat box down there or that way for you to ask questions for for me and for anyone that I'm actually taking on board. And today I'm so excited because I've got Robert Libbey, who is from Vancouver in Canada. And this is actually my second time chatting with Robert. He's developed a new concept around referral pain patterns and looking at it as more of a ligamentous than the traditional myofascial trigger point concept. But what I'm going to do is I'm going to get Robert to come on board and he can explain everything that's new and relevant for us as manual therapists. So come on board, Robert.
Hello, everyone.
Hey, it's great to see you. And as I said before, happy Canada Day.
A couple of days ago.
And tomorrow it's American Independence Day, the 4th?
I guess it's their July 4th.
Yeah. Well, we always say 4th of July in Australia, but everybody else does it the other way around.
Right.
So for people who don't know you, I'm really, really excited to unpack this because a lot of people are only familiar with our trigger points that we've all grown up with in college. So this is going to be an eye-opener for a lot of people. And just to remind you all, please put comments in the comment section and I'll feed them out to Robert. But before we get started, you'll see down the bottom left-hand side or right-hand side that I have got the wonderful sponsors who are Q Academy. So if you're interested in becoming a manual therapist in the massage or myotherapy, or potentially upcoming for an associate degree in myotherapy, then please contact the guys at Q Academy. They are Queensland-based, but they do face-to-face, online, and mixed learning, and they will help you transition from whatever you're doing currently. If you're getting bored with that and want to excel into a different space, the education system is amazing. I've taught there. I know how they do their accelerated learning. It's loads of fun. No one has a boring time at Q Academy, so give them a yell. Anyway, back to you, Robert. Tell me the Robert Libbey story. Give us the not-so-elevator pitch. I want to find out a little bit more about your background, where you came from and how you started this.
I've been practicing going into 31 years now. So registered massage therapist, started in 1994. Long story short, I had a number of patients that were complaining of discomfort and dysfunctions. And we had those trigger point charts on the wall, and they would look at them and say, that's not me. So I would hand them a marker and say, okay, well, then you draw you. So for about a decade, these really ugly trigger point charts became more ugly. And exactly, yes. And I was just really interested in knowing why these patterns, which seemed similar across all of my patients, we were not taught them at all. And they didn't fit into anything that I had studied. So I was talking with a naturopath that I work with, and he looked at them and went, oh, well, I've seen these before. These are pain referral patterns that were documented from George Hackett back in the 1930s and 40s. So I grabbed his research and looked at all of it, and then it just expanded from there. I took about another decade to look at. I've actually done three research projects, but yeah, just looked at all the information and the research into the pain referral pattern experience that people would comment on from, joint capsules, ligamentous tissue, articular tissue, and then went through and just did all the research for it. Wow. So these aren't mythical patterns. They are true patterns that are regenerated or are generated in the lab with subjects. They're your people that you have coming to see you on a regular basis, every day. So they are evidence-informed, research-based, and they're all real.
Hey guys, it's Paula Nutting, your musculoskeletal specialist, and this is that awkward, cheesy kind of part of the video where I ask you a big favor. So if you want great content and lots of information, you can see down here in the little testimonials, there's free manual therapy information. There's really cool stuff on necks, shoulders, backs, hips, wrists, arms, etc., etc. I've got amazing Ask Me Anything podcasts and vodcasts that you can get free access to. If you want to get that great content, can I please ask you 3 things? 1, can you please subscribe to my channel? 2, can you hit the like button? And as they say, just smash the heck out of that like button. The more information that YouTube gets to me, the more I can give content to you. And if you can click on the bell, that will also give you timelines for when I'm actually dropping something into YouTube so that you can access it really quickly. So subscribe, like, and click on the bell, and I'm hoping to get you as much great content as I possibly can. Paula Nutting, your musculoskeletal specialist.
They're all real.
You know, I know exactly the same feeling. We have that conversation around the neurolymphatic points and their pathways, and the same thing, getting information and going, how does this make a change? And then finding that the research is coming from the earlier in the 1900s, and then going, oh, I've got no research currently or that I can extrapolate that is going to give me a fast step up. So you are doing the legwork to be able to then convert old empirical evidence into something that standardizes up into research. But I'm 100% with you. I've lived that dream myself.
Yeah. Yeah. And there's still research being done in this area. Even just leading up to getting this second edition printed, there was research that I was discovering that had been published, a couple of months ago. So this is still an active area of interest for a lot of researchers in this area.
Yeah, I mean, pain pathology is amazing. Like this is our bread and butter, right? We have patients and clients that come to see us in pain, and we all want to try to help them as best we can. I'm going to get you to explain how it works, what kind of depth of treatment that you do, like how can we apply it? If you can give us some little tips and tricks for people to take away.
I'm going to just run through. Do you want to actually see the book?
Yes, I was looking at the first
book. So yeah, a little story about the first book. So this is the first book, Ligament Pain Referral Patterns. This was published in 2020. I had been teaching in Australia. Actually, I was there for a month, and I had done the research and had images all made and made posters out of them. And I brought the posters to the amazing massage therapist and myotherapist in Australia. And somebody said to me at one of the last courses that I taught there, they said, if you had this poster in a book, I would give you money. And I thought, I don't even know what that would look like. I never thought about the concept of these images being a book. So on the way home, because I had, 16, 17 hours in a plane, I wrote the majority of the skeleton for the book. And I was supposed to get home from Australia, have about 4 or 5 days in Vancouver, and then I was heading out to present at the International Fascial Research Congress that was in Germany that year.
Yeah.
And that was going to be on the 8th. On the 4th, I got into a very serious car accident that I was told that I should not have walked away from. Essentially, I was going through an intersection and a car blew through the intersection doing about 70 and it T-boned me dead center in the driver's side door. The whole left thorax was just crushed. In the emergency room, the emergency doctor and I, we were actually counting the fractures in the x-rays. And we got to like 12, 13, 14, 15. And he looked at me and went, "You have a lot." And what was interesting, what was going through my mind at that point was that I just spent 16 hours with my laptop with all of the research on these pain referral pattern experiences that patients have talked about, and I was living them, going,
Wow.
oh yeah, that costal margin does refer there, and that costal transverse joint, yeah, it does refer to there. So it's like, wow, isn't that interesting?
Wow.
So as part of the process of rehabbing the brain and everything else, you challenge the brain, you go through and you do the research projects, and you write a book. So that was the sort of the genesis of how the first book came to be.
Wow.
And and it was during that time that I did the 3 research projects, and I've since then I've redone them in order to update the information. So in the first book we had all of the and in the second book we had all of the neurological innervations for. Well, actually, you know what?
Yeah.
Why don't I just start? Why don't I just start with what I got?
That'd be unreal.
Because okay, so this is the book and the posters. You can see that, yes? Yep.
Mm-hmm. Absolutely.
Okay, so here's the front of the book, what it looks like, and then there's the back of the book with some key features about the book and a couple of nice little quotes from people. I have to say that I was incredibly honored and privileged that I sent out the first book to a number of PhDs and a lot of guys and gals that you and I both know that are in the profession that are just world-class thought leaders in this space. And I just said to them, it's like, if this is crap, I need to know. And if it's not ready yet, then I need to do more work on it. And the testimonials and the reviews that I got back from our peers were just amazing. And they've increased with this second edition. So it's gotten a little thicker. I'll just show you there.
Yes.
So
when you sent the copy to me, I went, "Oh my God, that's a big read." But
yeah, it's gone from about 200 pages to 6. Now, I don't know if you can still.
We've only just got the front cover that says "Review of the ligamentous-structular reflexes."
Yeah. Okay. Let me.
There we are. Oh, there's the front of the book or the back of the book. Okay.
There we go.
3.
There we go.
Yeah, perfect.
Okay, so just some really nice testimonials. So I wanted to make sure that this one also was peer reviewed. So, sent it out to a number of people from Canada, South Africa. Randy Dillon's amazing. Aubrey, Aubrey from Ireland, right? My really good friend Gail Headley was just, fantastic. Paul Kelly, and then we've got, Joe Musculoskeletal. I wrote a chapter for him.
Yep.
Charlie Peebles was just awesome to get to, to be able to have him write a testimonial that was really nice. And then Jeff Rockwell, Robert Schleip got back to me also. So just, I'm really honored that these people have got some really nice things to say about this work. So just a little bit of the tables of contents. Sure. So we run through some foundations, right? So we do some introduction to the ligaments, ligament structures and functions, how they get injured, how they heal. We look at some complex and evolving concepts in pain. So I talk about how pain is confusing, because with a lot of our patients, they're like, I don't understand why this is happening. And people keep telling me it's in my head. So we talk quite a bit about that. We get into the classifications of pain. We talk about the nociceptive apparatus. And then we run through the differences between somatic and visceral nociceptive discomfort, neuropathic pain, nociplastic pain, mixed pain, and so on and so forth. And then it just gets into like a really, really deep dive, looking at pain profiles, looking at, sort of a modernized perspective of the biopsychosocial sort of, concept. We talk about how the biopsychosocial concept is basically that. It's just a concept. It can't be operationalized. It can't be utilized in the clinic because there's no strategy to do that. And then we get into the history of documenting pain referral patterns. So that's globally pain referral patterns, not just the ligamentous stuff. And then we get into the meat potatoes, which is the neurological innervations, the pain referral patterns, and for the whole body. And then we look at the appendix, which is basically a lot of incredibly valid pain-focused questionnaires.
Oh yeah, okay.
I wanted to make sure that people were able to walk away with something that they could start implementing in practice. And these are all some of the most valid pain referral questionnaires that are out there that we have right now. So yeah, just some nice images. The inside of the book, we've got a chapter outline, an overview, chapter objectives. There's also a terminology section, so it breaks down into prefix, root word, and suffix, and then definitions, and then just some nice neurological innervation images. Just some of the things that I've taught at before. So I've taught at the RMT AO in Canada and Ontario, their 2023 Understanding Pain Conference. I've taught a lot at physiotherapy, physical rehab, sports medicine. So yeah, this is really just the tip of the iceberg. Like I said, I have a very intimate relationship with the pain experience and healing. Like you had said, Paula, there's lots of people that come into our practice. There's lots of different kinds of discomforts that come in. And a lot of times we're sitting there asking ourselves, like, what am I even doing at the end of the day? It's like, am I even helping any of these people? They're coming to us. They're looking to us to have the answers. We don't have any answers, or the answers that we were told from some guru in some class, well, that's not the answer. So both of us kind of leave frustrated, and you go and you take more and more courses. You keep looking for more answers. And ultimately it's just, a lot of us are really stressed. A lot of the students that I talk to, or a lot of clinicians that I talk to, not just in massage, but in physio and chiro also. There's a lot of stress. So hopefully, I know that I've used this book in my own practice on a daily basis, and it improves my competence and competence, because we've got lots of people coming to us in pain. They think that everything is broken. We're going to tell them that everything is awesome all the time. So in the book, we talk about mechanical properties. We talk about the sensory properties. For those of you that are here, I want you to think about ligaments as just different densities with specific functions. So your liver and your kidneys are different densities with specific functions. Ligaments, joint capsules, no different. Again, different densities, specific functions. Sometimes they're happy. Sometimes they're a little cranky. And this is how I want you to think about how a ligamentous injury occurs. It's basically just pulling some tissue away from a cotton ball. So again, how do they happen? They happen with a high frequency repetitive motion, or you get that fast stretch with the ankle sprains.
It looks horrifying.
I know, right? You're talking about the cat, right?
Yeah, totally. Oh
yeah.
God, the cat.
The cat. Typically we want to be living in the Goldilocks zone, where you break down some tissue, you eat really well, you give it some rest, and it builds back up again. But you get your full contact elite level athletes, like your gardeners, that will go into the garden for 8 hours, 3 days in a row, and they can't understand why 6 weeks later they're still feeling injured. So we talk about that in the book also. Okay, so here's the 3 projects that I did. So we looked at neurological innervations, we looked at ligamentomuscular reflexes, and then we looked at the research that documented the pain referral patterns and how referred pain occurs in the body. So we all remember our dermatomes and our myotomes. So a dermatome is an area of skin that's innervated by a peripheral nerve that's then innervated by a dorsal root ganglion. Myotome is a muscle tissue or group of muscles that are innervated by a peripheral nerve and then dorsal root ganglion. But what about your joint capsules, ligamentous tissues? We know that when you sprain your ankle, the ankle hurts. Well, if it hurts, then it must be innervated. So I grabbed all the research, and so I'm now using the term arthrotomes. So we have dermatomes, myotomes, and arthrotomes. So the arthrotomes are the joint capsule ligamentous tissues that are mainly supplied by afferent nerve fibers from the dorsal root ganglions from any given spinal nerve. And we've got a complete compendium of the nerve root, the peripheral nerve, and any of the joint capsule ligamentous tissue that's been innervated for the whole human body. So that's axial and peripheral spine.
My God, that would have taken, I can't even imagine how long.
It's a long time. So now you can go to your patient. You can say, okay, well, you sprained your ankle, you sprained your, lateral fibulocalcaneal ligament. It's innervated by this peripheral nerve that's coming from this dorsal root ganglion. This dorsal root ganglion also innervates these other tissues. So there's potential for, some protective mechanisms that are happening there. And then I've got the neurological nervation images, all based on research. These aren't recreations of Netter. They are new images based on the description of the nerve path in the research. So that took a lot of time.
Unbelievable.
We've got the ligamentomuscular reflex. So again, there's a little bit of research in humans, but there's a lot more in veterinary medicine. So I didn't include it in the book, but I included how the ligamentomuscular reflex occurs. And the reason why it's important to know this, for example, we've all got patients that have had some type of fall on an outstretched hand.
Yeah.
And they will have pain or discomfort or dysfunction in their wrist, but then about 6 or 8 months later, suddenly their elbow hurts.
Yeah.
And they can't figure out why do I have golfer's elbow? Why do I have tennis elbow? Where did that come from? I don't play that sports. How did that happen? Well, in the wrist, you have a scapholunate interosseous ligamentous tissue that's innervated. And as part of a stabilization mechanism, your common extensor and your common flexor muscles will co-contract in order to try and stabilize that ligamentous insufficiency.
Yeah.
So 6 or 8 months later, now you've got your pain experience at your lateral and medial epicondyles.
Yeah, we always say Peter robs Paul or Paul robs Peter. Where you have looseness in one, you're going to have more restriction to stabilize it. And it always comes mostly proximally, but distal occasionally in my experiences. But yeah, like a wrist is definitely going to have more support, as is a shoulder. So I guess what you're saying is cascading. If you don't manage the elbow, it then reproduces up to the shoulder and neck. Or it can avoid this elbow and come straight up to the shoulder. Is that ever possible there, Robert?
Yeah, it sort of depends on how it happens and the neurological innervations that occur and sort of how the referred pain is happening with that person. Actually, we're going to get into that in about 2 seconds. So anyways, we documented the research on how referred pain occurs. I want to make sure that you are seeing this.
Or just a pair of shoes that I'd like.
There we go. So that ligamentomuscular reflex, it works in series or in conjunction with your voluntary muscle movement patterns. So it works sort of behind the scenes to keep you upright. And then we documented all the pain referral patterns for the joint capsule ligamentous tissues for the whole body also. And then how referred pain occurs. So there's a ton of research on, repetitive loading, fast stretch, tissue damage leading to central sensitization that leads to that pain perception and that referred pain. Briefly, there's 3 ways that referred pain happens. And we get into this really, really deeply we go down the rabbit hole into each of these in the book. So there's a neurophysiological mechanism. You get a dorsal root ganglion that gets sensitized because the tissue that it innervates has become irritated. It creates a inflammatory cytokine sort of soup that migrates anywhere between 3 and 6 levels. So now you've got a dorsal root ganglion 6 levels down that was just minding its own business, having a really nice day, and then it got all cranky because this inflammatory soup sort of migrated into its space. Well, now it refers, it actually innervates other tissue. So there's your connection between, something happening proximally and affecting something distally.
That's amazing. I'm just wondering how you actually managed to get that research of that. So you went into the to work out how much of the P substance or whatever was creating the problem. What mechanism did you find that?
So what's really interesting is that with social media, you can stalk people. So yep. I had found the researcher's name was Thomas Graven Nielsen, and I'd found him on LinkedIn, and I sent him a bunch of messages. It's like, dude, I want your research. Yeah. And he was gracious enough to send me his 24-page research paper where this was documented as a part of that.
Wow. Okay.
So again, it's not me. It's the amazing PhDs that are out there that are doing this amazing work.
Well, that's what the heck you could have got. I mean, like, I know it can be done, but how do you manage to do that when you're not in a research environment 24/7? So, wow. Okay. Well done. Thank you, Thomas.
In today's world with AI that's out there right now, it has just completely opened up the ability for anyone to gather research in their area of interest. With the second book, I used a ton of AI in order to acquire the research. Now, a lot of people will sit there and go, oh, okay, well, we've seen how ChatGPT lies to you and it gives you false references. Yeah, it does. That's why you need to do your due diligence and make sure that you grab every paper that you can to be able to say that you've read it. You can see that it hasn't been taken out of context and that it's truthful and factual. So yeah, for every piece of research, let's just find. So for every piece of research that's in here, for every chapter, I have every paper and I've read every paper. So yeah, it's just a matter of, and you know what, with a lot of researchers, if you find out who the researcher is, and if their research, for example, is behind a paywall, like with Elsevier, you can actually just contact the researcher and they'll send it to you. I've contacted so many researchers, and they're so kind that somebody is interested in their area of interest and that they're going to put it to good use. They'll give you the research.
Yeah.
So yeah,
it's the same as you guys were given your time to improve the quality of education on this portal. So like I've always gone, well, all I have to do is ask, and like you and James Wazlowski and John Sharkey and Robert Schleip, everyone has just been gracious and said, absolutely, sure. Let me, Michael Copeland. So it just ask graciously and you normally get what you need, because it's to help everyone. I just can't believe the quality that you got from, I love AI. My bag for content and stuff is more Gemini. Google Gemini finds much more quality. I love Chatty. She's my girl for the newsletters and stuff. So they both have their paths. Did you have more slides that I jumped in on? Will you be familiar?
I've got a couple more, but I'm gonna skip through some of this stuff because we want to talk about a little bit about well, how do you integrate this into your practice? Yes. And we want to just remember that everything that we do is it's a person-centered approach, right? So this is information from, again, this is from 2024 where they've documented exactly what do we need to be doing as clinicians, and I think all of us are doing a pretty good job. Some of us are kind of still interrupting the patient within the first 3 to 8 seconds. And I think it's just I think if we just recognize that what we do with how we say things, the terminology we use, the narrative that we use, that actually contributes more to our outcomes than what we do with our hands. It's a blend of both. But if you tell somebody, you know, how horrible it is, the things that you're finding in them, as opposed to, this is the best thing that I've seen all day, this tissue is awesome, this is amazing, you're going to have a completely different outcome from both of those things. And that's the one thing that I talked about in the keynote speech for the Massage Myotherapy Association's national AGM, is that, you know, just tell people how awesome they are, and you get amazing results. So a person-centered approach is really key. You know, you've got to have a nice therapeutic relationship where both people trust each other. And, you know, besides manual therapy, we've got to really make sure that we're getting them active. And if you don't know how to make them active yourself, then you have to have that referral network of amazing kinesiologists and personal trainers, and active rehab professionals that will be able to do that, because there's so much research that shows that activity helps with depression, anxiety, psychological distress. It is an under-recognized coping strategy. It shows, you know, that there's higher pain tolerances with increased activity levels. It's the best thing that you can do if you want to get away from pharmaceuticals. So, you know, empowering your patient, educating them, giving them baby steps, making sure that they're mindful of how they think about themselves and what's going on, getting some manual therapy, because manual therapy is awesome. Making sure that they're getting some sleep, because sleep is awesome also. And then, you know, making sure that they're doing something that's active, that's fun, that they enjoy to do. So we just want to really create change and facilitate growth. We don't fix things any longer. I never say that we fix things. I don't use the F word in practice.
No, all right.
So that's basically it. I do teach ligamentous articular strain techniques. Again, that's an old technique. It's not mine. It's Andrew Taylor Still's from the late 1800s, early 1900s. He taught it to two people, and then they taught it to two people, and it still gets taught. But I've sort of taken it from the science of the day that it was formed in, and I've applied today's current evidence-informed, patient-centered research and science to it. So my explanation,
someone to understand what that actually is, a ligamentous strain technique, because they might actually be doing it and not realize that they're actually doing it.
Yeah, there's a lot of people that are probably doing something that's similar to it. They might not just be as fine-tuned or thinking about the tissues that they're working on. But yeah, so if, for example, we had a gentleman who had a clavicle fracture up on stage, and it hadn't been reduced with plates or pins or anything, but it had a dysfunctional force coupling pattern. So, you know, when you take a deep breath in, it should roll anteriorly, posteriorly, superiorly. And when you take a deep breath out, it should roll anteriorly and inferiorly. And his was going the opposite direction. So suddenly you've got compensatory muscular tissues that are setting in place. When that happens, you get fascial dehydration and compression on neurovascular bundles that happens. You get altered functional patterns. So now you've got other tissues that are overworked and underpaid. That all contributes to, you know, just all the mess that we see our patients walking with. So just getting that clavicle to function in a force coupling pattern that's normal or more normal, it takes it from being in that sympathetic state to a parasympathetic state. It causes a diminishment of those protective armoring mechanisms. You know, you can get a decompression of the neurovascular for the brachial plexus just by working on that area, and you regain shoulder function really, really quickly. That's just one sort of example.
So, you know, I'm going to ask you, what does the technique actually include? Is it like hold and rest? Is it like positional release techniques? Is it more like strain, counter strain? Is it thumping? Is it dry needling? What is?
So it's not it's not like an HVLA, like a high velocity. It's very slow. It's very specific. We're looking for that to find where that movement pattern is, depending on if what the discomfort of the patient is. If they're really, really sensitized and it's really, really uncomfortable, what we'll do is we'll load the tissue into the direction of ease. So it's kind of like a positional release technique for ligamentous tissues. In that position, it sort of allows the nervous system an opportunity to become more parasympathetic than sympathetic. Or what we can do is we can actually go into the dysfunction. We can go into the barrier, and we're looking for that communication with the nervous system. So we're looking for that communication with that nociceptive apparatus. And when we work with the tissue, you get that strain relaxation sort of effect that we saw in that bell curve, where you can place some strain into it, and then you can come off of it. You can place some more strain into it, and the curve changes every time you do that, and you can increase range of motion really, really quickly. You can reestablish that force coupling mechanism.
Yeah, gorgeous.
So and it's slow.
Yeah. No,
some of these holds, some of these holds are 90 seconds to 5-10 minutes, depending on the amount of protective mechanisms and armoring that have been in place. And a lot of the audience, they were really shocked at how long it takes to sort of unprotect or disarm this nociceptive system.
I noticed that you did, in one of your forwards, you've got Robert Schleip, whom I love. He talks about hyaluronan and getting some more movement and liquidity in there. Would you say that that's also inclusive of what's happening in that space?
Definitely. When you're working, when you're working in through those tissues, remember that the joint capsule ligamentous tissue, it runs in series with the musculature, with the fascial tissue. When you're working with that tissue, you have to be either levering the tissue or being at 90 degrees with it. You can't really just like grab the skin and move the bone. You have to actually lever the bone. So there's your valgus varus sort of stress for the elbow. And yeah, you definitely get an increased production of hyaluronic acid. Obviously, working with the joint tissues, you get an increase in production of synovial fluid. So yeah, absolutely.
Yeah, wow. And I want you to give us an example of how you would treat and manage. I was looking at some of so that lateral ankle sprain, which is a typical thing that we will see. Where is the common pain for somebody else? Oh, maybe I've gone. Can you still hear me? Am I here?
Yeah, try again.
Yeah. Okay. I suddenly went, yeah. So can you unpack for us what the common referral pain for ligamentous for lateral ankle sprain and how you would treat that in your clinic?
Okay. So it depends on what degree of the ankle sprain has come in. Obviously, if it's 100% tear, there's nothing there to treat. As far as the ligament joint capsule is, you're treating all the surrounding tissue. But if you are treating a first or second degree sort of tear, either 50% and above, I guess it depends on first what your comfortability is with working with those tissues. Now, a lot of research previously has been done and published that showed that typically we don't want to be treating or loading into those tissues until about the 3 to 6 week point. I don't like that. In any of my own personal injuries, I have always loaded the tissue within 24 to 48 hours. I have rehabbed a lot faster. I've seen it done with my elite level Olympic gymnasts, powerlifters, football players, soccer players. And now we have the research. So there was a video, I could try and bring it up, but it was from, it was just put out recently by, I think his name was Keith Barr, who's a professor of physiology and anyways, he's got a PhD, and this is his area of interest. And his research showed that they start loading the next day. And the very next day, they start loading it within reason, right? So graded exposure, but they start loading it the next day. And they had an ACL reconstruction on a football player. And they had talked to the surgeon. The surgeon's like, no, we don't want to load until about, 6 or 8 weeks. And he said, well, why don't we load it like day 6? And the surgeon reluctantly said, okay, well, go ahead, do your protocol, load him at day 6. Well, that player got back to activity a full month before what they were expecting. So with ligamentous articular strain techniques, I like to get my hands onto these acute injuries as soon as possible. If I can get my hands on the next day while it's still acute, we can make amazing effects as manual therapists. So for example, with your fibulocalcaneal ligamentous injury, typically what happens is that there's either an inhibition, a stimulation, or a co-contraction that occurs between tib anterior, tib posterior. Gastrocs will get involved, and it will actually put the foot more into a plantar flexion position rather than a neutral position. And when that happens, your talus actually gets drawn anteriorly. Now, when the talus gets drawn anteriorly, you have a diminished force coupling mechanism, so that when you try and bring your toes to the nose, that talus actually gets pinched on the very distal end anteriorly of that distal tibia. So if we can encourage the talus to sit in more of a neutral position, and we can manage and maintain a normal active range of motion for the calcaneus and for the fibula, then we're going to have better outcomes. The other thing is that when that injury occurred, when that inversion sprain occurred, that fibulocalcaneal ligamentous tissue, it actually pulled the fibula distally away from its proximal attachment. This is why you have semi biceps femoris discomfort and hamstrings protecting and guarding afterwards, because that biceps femoris attaches onto this posterior superior aspect. So we treat the hamstrings, we get the fibula moving, because what will happen is that the hamstrings will try and protect the ankle, like you said, from proximal to distal. It will try and protect by pulling that fibula up into the tibia, and then it doesn't function, it doesn't move. So work on the hamstrings, get the fibula moving, work with interosseous membrane also, which gets into that anterior posterior, tib anterior, tib posterior, and then working with the talus and the calcaneus just to make sure that we keep the range of motion that we have.
Yeah.
So that whole process from the knee to the ankle, that's an hour. We don't go anywhere else.
Okay. Yeah, lovely. I mean, like that would have been a real eye opener for the Massage and Myotherapy Australia people, because everyone is like that. It's so new, and a lot of them in our courses don't get to that kind of depth of information anymore. That when you and I went through 30 years ago, we had a 2-year full-time structured course. Like we had to learn McGee, Orthopedic Manual and Assessment. That book. You remember it? You probably got it there.
I've got it.
I normally use it when I'm standing up to talk on these things. I use it to elevate it, and Chatow's the Travell and Simon's books 1 and 2. They're great to elevate my computer so I'm standing the right height. However, I know what they're used for. I love that you've done that. What we're going to do is I'm going to get a quick marketing for anyone who's interested in the Q Academy. We're going to give you a little bit of a short promo, and then we're going to come back and chat more to Robert about what's happening in the future for him.
My name is Jade Afu. I studied Cert 4 massage in 2014 and then went on to remedial in 2015. I was working in ASICs. I was retail, Lorna Jane, The real reason why I went and studied was my daughter was, she's been quite sick for about 7 years on and off. She's had a couple of chronic conditions. So I found it hard working in a job and having to leave because my children are sick, or I've got to go to hospital, or there's just so many things going on. For me, I needed another option. I've been set up for about 8 years now, working from home. Having a home business has been like such a blessing to my life. I don't think I could have done what I've done somewhere else just with my own circumstances. My life's very busy. I've got 3 kids. And this year has been a little bit different again because now I've got 3 kids playing sports every afternoon. So I do try, if I can, work in between school hours. I feel like you can make it work to your advantage. So you can either work as hard as you want and be stressed and all the things, or you can make it flexible.
As I said, there's such a good college to learn through. I just remember having games like they do a 20-minute, then there's a brain break. So you automatically get time off. And we would be in 2 separate rooms with a block, but not all the way to the ceiling. So you could actually play games. So we'd be playing, tennis rackets with minties or jaffas and hitting them back and forward over to these unseen people in the next room. 2 minutes of that, your brain is wired to learn. So if you're interested in upskilling from your just basic massage qualifications that you have now to something a little bit higher, contact the guys from they are brilliant. Robert, I'd love to be playing with the ankle forever because I and the stuff we did with strain, counter strain, Larry Jones and stuff, which is brilliant as well. Sounds like there's a little bit of an influence of his work in the joint space. And he always talks about that contralateral reflex of contraction. So really like working, loosening off the medial deltoid ligament in that ankle to assist in all that. So I don't know whether that's part of the picture or but that's just where my brain was going. Mobilizing navicular heads and like all that next part through and fibular heads. I'm off topic. Talk to me about the questionnaires because I love that you mentioned that you have questionnaires. So do you offer these in the clinic to your patients to be able to go through? And are there different questionnaires for different like shoulder, hip, back, knee?
Yeah, the typical ones that everybody's probably used to is the Austri questionnaires. So they have ones for every part of the body, and we use them in clinic all the time. If you've got a brand new patient or you've got an existing patient with a brand new injury that they're coming in with or dysfunction, then we'll start them with that questionnaire, and then it's just a matter of every 3 weeks or every once depending on how often they're coming in. Typically it's about every 3 to 4 weeks we'll run through the questionnaire again, and the questionnaires are all really well laid out so that you can actually compare both of them and you can get a score to see if what the outcomes are, if you're actually having improvements or if you're not having improvements. And if you aren't having improvements, then you do a reassessment and what are we missing? Do we need to refer you out? So they're just great questionnaires to go through. So I included them in the book. They're going to be for those people that do purchase the book when it goes online, they'll also get access to download those questionnaires as a PDF so they can start implementing them into their practice. And again, these are questionnaires that you'd have to go out and search everywhere and try and find out if it's actually if there's any validity to these questionnaires or not, because there's a lot of questionnaires that are just crap, to be honest. And they don't have any validity whatsoever. They don't measure anything, and it's just a waste of time. So I not only got the questionnaires, but I went through and I found the research that assessed the questionnaires for their validity, and anything that showed that it wasn't valid, well, then I didn't use it, obviously. So these are the ones that have the most validity in use in clinical practice. And I still practice clinically. I'm in the practice, 3-4 days a week, still seeing patients for an hour at a time each. So I think it's really important. I like how the clinical practice supports the teaching and the educational aspect of what we do, and the teaching and the educational aspect and the research and the science, and of continuing to, try and be as, as forefront as possible. It contributes to the clinical practice.
Yeah.
So, you have to have both.
Yeah, agreed. So much brilliant stuff here. With therapists, okay, so go to buy the book when it comes out online. I'm one of those people that goes reverse that when you came out to Australia 2020 or pre-2020. Is there posters that people can use for their patients to say, those are up there just to get a guided idea of people when they go, this is where my pain is. I go, well, it's possibly stemming from, and let me see if we can reproduce. So it's about breaking down part of the assessment tools, but you can use that for your patients and you're getting the slide up perfectly. That would be great. I know therapists will use those. People love
Yeah,
it.
absolutely. If you go to ligamentpain.com, you can purchase these posters. The book, not quite yet, but soon. But the posters, yeah, ligamentpain.com, you can go there. Again, I have all of the images for the axial spine, for the peripheral spine, and again, it's all based on published, documented research. So a quick sort of story about that was that I had a therapist who had a patient who was a nurse, and the nurse was transferring a patient. The patient transfer didn't go well. Now, hospitals have insurance policies, and they've all told their staff to just let the patient drop. But that's not what we do as humans, right? We try and save the patient. Well, she saved the patient, but she got injured in the process. And about 8 months later, she'd been to see, again, it's one of these stories, right? I've been to see everybody. My ankle still hurts. So she sees my amazing associate who's trying to work on this ankle, and they're not getting anywhere, just like nobody else has. And she brings her into me. I'm on lunch break. It's like, well, tell me a little bit more about how this injury happens. Well, it happened in that she fell on her coccyx and she had some pelvic pain. But then what was worse was that she immediately also had this heel pain. So everybody figured that she had sprained her ankle. So they ignored her coccyx and they all treated her ankle for 8 months. So I have these posters behind me on my wall in my office, and she's looking at me, and then she's looking at the posters, and she's looking at me, and then she looks at the posters, and then she bypasses me, and she points to a sacrotuberous sacrospinous pain referral pattern, which and a sacrococcygeus, which has a specific heel pain referral pattern, like a calcaneus pain. And she starts like pounding on the image. This is me. This is my pain.
Oh.
What the hell is this? I've never seen this before. Why doesn't anybody know about this? So we go through and we explain the research going into the ligament pain referral patterns. And hey, while you're here, let's treat a little bit of sacrotuberous, sacrospinous, and a bit of that coccyx area. So we start doing that. And it's nice and slow, informed consent, everything. It's all external, close on techniques. And she starts saying, she's like, oh my God, my heel is killing me. That is burning. Whatever you're doing, it's making it worse. Keep going.
Yeah.
We're like, you want me to keep going? Yes, keep going. Because the longer that you're holding on to it, it's starting to feel better now. But you're not down at my ankle. You're up at my coccyx. What is happening? So again, we run through the research and we explain the neurological innervations and the referral patterns. Long story short, I tell a long story. Three treatments, showed my associate how to treat. She saw my associate for 3 more treatments. No more heel pain. Something as simple as that. Like that, it's one of those things where it's not always like that. A lot of times it's a very serious condition. It's going to be there for a long time. There's been structural change, bone and tissue remodel in response to stress. So sometimes it's just things have changed, and you try and make it as good as you can. But there's always those stories that sound too good to be true, and they sound too good to be true because they're really, really rare.
Yeah. But the one takeaway from that, everybody, get the history and get all of the history, and don't assume, because it's an ass out of you and me, like, the whole, as they always say, but that you just put a little bit more time to work out the causation at its primary state. And for me, that's the biggest nugget to take away, because people don't do that enough.
Well, my father used to be an investigator for the RCMP, and I think I've acquired a lot of those genetics. So my patient interviews tend to be more interrogations rather than interviews.
Have you spoken to John Nickelston?
No.
John Nelson he's with the AMTA. He's been chair off and on with them. But he's always about get as much history and that patient or client consent and informed decision making. Walt Fritz is another one that does that. But it's about don't assume. Give them the tissue's always going to be on a pathway to heal. Your body is doing that. It's the brain that changes that game that you were talking about earlier. And Whitney Lowe talks about pain science. Like, there's a lot that Whitney and Till Lukow talk on with the brain. So the second, as you said, I think 8 seconds or something, when they come into the room, you've got to make them feel like they're not broken, or not that it's not horrible, and you can actually be part of their healing process.
I had, I tell the story that I had a 90-year-old Chinese patient, male Chinese patient, and he was a master at teaching Tai Chi. Wow. And he's 90. So he did something a little bit beyond what his 90-year-old tissue wanted to do, and it got cranky. So he had a cranky shoulder, and he went and saw somebody else who told him that it was the worst shoulder that they'd ever seen, and that he had frozen shoulder, and that he had to stop doing the thing that he loved to do. And we've all heard this before, that you've heard the stories of the person that tells the patient they're the worst case ever, and this is going to be a career-ending injury that they have. What a horrible thing to say to anyone. Like, this is the worst shoulder I've ever seen in my whole career.
Yeah.
Wow.
Really?
So, yeah, really? Yeah. So he comes into me. He doesn't have the frozen shoulder. He has a cranky shoulder. His nervous system's a little cranky, and he's getting a pain experience because that's the whole process of that nociceptive apparatus. Yeah. And I'm moving his shoulder around, and I'm loading into it. I am not like holding back. I'm working this guy over. I'm like, dude, this is the best shoulder I've seen all day. You have the shoulder of a 19-year-old. And he's like,
yeah,
a 19-year-old? Like, yeah, this is awesome. And he's like, tell me more how awesome I am.
Oh, that's gorgeous.
Like, that treatment, we had regained 80% of his functionality because of the psychological limitations that had been placed into him. And we have those dims and sins, right? So we have dangers in me and safeties in me. And if you think an action is going to be dangerous, then you are going to lean into that. And you're going to compensate your life to a lesser degree in order to accommodate that sort of perception of it being dangerous. Sometimes it is really dangerous, and you should really, put a cast on it because your bone is sticking out. But other times, it's a safe action.
Yeah, yeah. I couldn't agree more. And people are so fickle, and we love to hear little bits of gold nuggets about ourselves. Some people love the whole ego about, this is the worst you've seen, right? Like, so I can tell all my friends this is the worst. And they don't really love it when you say, you know what? Actually, no. Like, passively, we've got full range going on here. So there's nothing like really dirty and nasty in here. Your muscles are just guarding. And it's like you've slapped them with a dead fish. Like, they don't want to hear stuff at all. But,
yeah, they say, okay, so I need to see what, like 3 or 4 times a week for the rest of my life? I'm like, no, come back in about 10 days and we'll see how you're doing. But go be active and go do all these things.
Yeah.
If I don't need to see you, then go play outside.
Yeah. That's the question I was going to ask, because I know that patients who have pain or clients who have pain are really remiss at moving because of the depression. So it's kind of like, how do you, like, I try to find a way for them to go, my keywords are what movement gives you joy, because they have no joy. Like, that's the first thing, that the pain saps joy from your body. And it might just be like, for one of my little old ladies who had a lot of like fibromyalgia kind of symptoms, her thing was just being with one of the grandkids and putting them on her knee and bouncing them and singing nursery rhymes. And that was her joy. But God, it's not as easy. You talk about getting people to get up and do exercise.
Yeah, with you sort of have 2 sort of categories, right? We have our elite level athletes that are our gymnasts and our powerlifters and our football players and full contact sports that way. And then we have our elite level athletes that are our grandmothers and our gardeners and our knitters and those elite level athletes. And the first elite level athletes, it's really hard to make them stop. Like, sometimes they need to slow down. Like, I'm not trying to make you stop completely, but you need to slow down a little bit. Like, instead of practicing 7 days a week, maybe you practice 5 and you have a couple of rest days in between. But the elite level athletes that are the gardeners and the grandmothers, it's really hard to make them go, to get them started doing something. And that's where the baby steps and that graded exposure kind of comes into play. Sometimes it's a psychological thing that has been placed into them. I had a female marathon runner and she was winning and she had an injury, and some active rehab therapist told her it was the worst thing ever and that she would never be able to run again. And that really, so she stopped because of the fear of breaking something even more and being more broken. And when she came into me, she was actually suicidal because it had gotten that bad.
Yeah.
So my thing to her was, okay, well, what's the one thing that you love to do? She's like, I love to run, but I can't run. Why can't you run? Oh, I was told that it was the worst thing for me ever. Well, that's, for what she had, that was not true. Okay, so if you could run, could you maybe try running around the block? Could you try going for a 1K run? Like, you might not be able to run marathons again, but if you give me an opportunity and work with one of my active rehab people in my office, if we could get you back to running 5K 2-3 times a week, would that be okay? So, that was life-changing for her.
Yeah.
And a lot of times, there's some motivational interviewing that strategies that we use, right? So, well, on this hand, you say this, but on this hand, you say this.
Yeah.
And then you let them choose the path that they know they need to choose in order to live a better life. And
if you know the right one,
and that takes time.
Because that's NLP. You always say, do you want the harder option, or do you want the second? A little bit of
I had a guy who said, I've made a real positive change. I've given up donuts. I'm like, okay, great. He's like, yeah. And I swapped it in with something else. I'm like, what did you swap it in with? He's like, bagels.
From far north Queensland, who dropped 18 kilos of weight. He was chunky, big guy, big trucky. And his only change, he said, I've stopped drinking full strength beer and I've turned to, it's still full strength, but the low carb beer. So changed to the low carb and dumped in like 3 weeks, 4 weeks, like some ridiculous amount of time, probably because there's so much diuretic in it. There's part of that picture. But his wife was almost suicidal because she said, I have been trying to lose weight myself and I just can't do it. And his old mate swapping 4X heavies for Carlton, whatever it is. Oh,
it's just baby steps. And again, taking the time, like everybody seems to be in a rush to get their patients on the table because they think that their net worth is, the amount of techniques and how many hand movements they do in an hour that, contributes to the cost of the treatment. It's like, no, that's quantity. We're talking about quality. And there's a number of times where I've had patients where the interrogation or the interview, the recatching up, hey, how are you doing this week? That's 40 minutes because we're trying to get them on a different path than the one that they don't want to be on any longer. And then we'll do some hands-on, some close-on techniques. But a lot of the times it's, I'm not a counselor. I'm not a psychiatrist. I'm not a psychologist. I'm not stepping outside of my scope of practice. A lot of the times we're just, we're letting them talk.
Yeah. Active listening. Okay, so I suddenly realized that ticker tape downstairs that talks about following Paula hasn't actually included your website details, and I'm going to be having a bit of a chat to the team afterwards because that should be all about you, not all about me.
That's okay.
I just suddenly went professional, not. Can you let everyone know what your website is so that they can come on? Oh, there you go. Oh, Robert Libbey, RMT.
There you go. You can go to lastsite.ca. So LASTSITE, lastsite.ca. So that's for ligamentous articular strain technique. There are online courses that they can access there. Now, a lot of people, they do the monthly subscription, like the gym membership, and then you never use it, but you still pay for it. And, 2 years later, you've paid hundreds of dollars for the stuff that you've never used and you've never accessed. I don't do that. You pay once and you get lifetime access because that's how I like to have it. And I hate having to have a subscription somewhere, even though financially it makes that person a lot of money. I never found it benefited me. So that's just my own personal thing. So lastsite.ca. And then for the book and for the posters, they can go to ligamentpain.com and they can grab those there. You can contact me through both of those websites also.
Great.
And then if you do a search for me on YouTube, you can watch some free videos of me demonstrating how to treat with ligamentous articular strain techniques.
Fantastic. That's great news. And I'm going to do a similar plug because there's a mile of content on my YouTube channel because I never plug myself. YouTube channel, Paula Nutting. There's oodles and oodles and oodles of DIYs that you can send out to your patients and clients and stuff to help you. And my mentorship page is a monthly subscription page, but that's okay. I don't care. I'm going to give it a wrap because you get Monday through Friday, you get a daily information. You get all the stuff that we're getting here. All of these interviews are kept in perpetuity on that page. We've got stuff from a whole pile of people. We've got current research. So there's loads and loads of educational stuff and quarterly meetings, like live face-to-face one-on-one meetings.
Now that's worth it. When someone does that, where you know that they're actually going to be present in a meeting with you, that's worth it. That one-on-one I like to have.
Yeah, we do the one-on-one to find out what were your goals that we had 3 months ago. What have you hit? What haven't you hit? And what can I facilitate to get you to the next, whether it's getting employing another person to work in your clinic, to set stronger boundaries with the guy who owns the place, and that's where AI is great. But like a whole pile of stuff. Plus we do quarterly or every 4 months, we'll actually do a webinar where we're doing education. Now, there's loads and loads and loads of stuff, and they're a fun bunch, which is what we all love. But I'm going to say goodbye and thank you kindly. I'm just going to also show, this is my Costa Rica Pura Vida shirt, and a shout out because the last 2 interviews we had with Nate, with Tammy McCure, and with, oh my God, Scott, Gordon, can't pronounce his last name. And they are all the beautiful guys who worked with Eric Dalton. And again, blessings to everyone who remembered Eric. He was such a beautiful human being, and he's sadly lost. So, Robert, thank you for coming. I'm going to send a little heart out to everybody, and if you want to do the same, you are more than welcome. And we'll hopefully get a chance to see you again when the book's out, and we can talk more about it.
Yeah, absolutely, definitely. Yeah, I'm interested in the Q Academy also because the one thing that no one knows about is that on the other side of this, I've developed the curriculum to be implemented into massage therapy curriculum, physio, and chiro curriculum. So, like what you were talking about, you do a little bit of intense work, and then you go and you play a game, and then that changes your mindset, and right. So we have visual, auditory, reflective, and kinesthetic adult learners.
Perfect.
So I've developed all of that to be implemented into curriculum because it's just so easy, right? If you teach joint mobs or spinal orthopedics or regional orthopedics, and you're doing anything with a joint, all of this information can easily just be dragged and dropped into a PowerPoint presentation and enhance the learning abilities for the students.
Perfect. That sounds amazing. Well, we might see if I can get you in contact with Robert, the other Robert for Q Academy, and see what we can do in that
That'd be
space.
awesome.
Yeah. Everybody, thanks for coming. I haven't actually got someone linked in. There's a woman that I'm in the process of dragging some information from, and I'm hoping that we might get. I'm just going to let you know so that she can have the surprise as well. Her name is Lorianne Green, and she is a body worker and has written a new edition of Save Your Hands. So that's for manual therapists. So perfect. Well, we'll get her next month, and then the month after, I'm off to Tahiti sailing for a few weeks. Yeah.
That sounds horrible.
I know, doesn't it, right? Thanks, everybody. We'll see you next month. Take care.
Thanks, guys.